I have the pleasure of kicking off sort of a two-part discussion here. And we're going to start with a focus on monkeypox and a one-on-one interview with Dr. Rosamund Lewis, who's the WHO's lead on monkeypox. And then we'll sort of transition into a broader discussion about pandemic preparedness with a few other guests, two of them joining in person and one online. I don't get much time with Dr. Lewis, so I'm going to jump right into my questions. First of all, thank you so much for joining us from a long distance. Really appreciate it.
Good afternoon, Michael. Great pleasure to join here.
I wonder, Dr. Lewis, could you start just by just lay out the sort of landscape for us? Could you characterize the state of the monkeypox emergency as you currently see it from your perspective? Where are we in this story?
It's a fascinating story. It's a story that is a little bit unexpected. In retrospect, not that surprising when we know about monkeypox and the history of smallpox eradication. So we're in the early phases of an outbreak now, which started in May, and we're now September. And so we have seen significant numbers of cases. We're up to 61,000 cases now in over 105 countries. In all regions of the world. So it's really an unprecedented development that we have monkeypox cases in almost half of the countries on this planet. And that it started in Europe in May and then moved to the Americas. And so we're really seeing a situation where some countries are now entering a phase of a more mature outbreak, where some countries are starting on the downward trend of the number of cases, whereas others are really just beginning also still to pick up. And countries have very different situations, very different contexts, very different access to resources, and very different capacities.
That's really helpful. And I think one of those differences in context is that we have a set of countries where the disease was endemic, and now a set where it was not, to which it has spread. And for those of us who, have sort of been trying to process the experience of the COVID-19 pandemic and a lot of the equity and inequity factors that came along with that, how is it that once again, we've sort of ended up in a situation in which countries where, in this case, monkeypox is endemic, do not have access to the treatments and tools to fight it, but those to which it has suddenly spread for the first time, or maybe, in very rare cases, are able to control those resources?
Equity is definitely one of our primary concerns for this outbreak, as for any other. And the situation is, on the surface of it, a bit perplexing. However, monkeypox has been around for a long time. The disease has been known since it was first identified in a child in 1958. So it's not something new. And in that regard, there has been quite a bit of research and a bit of work done in the countries where it was known to be, it is a zoonotic disease, right? So when you say endemic, what we're saying is that there's, the virus circulates in certain animal hosts and then can spill over into human populations. But because the world stopped vaccinating against smallpox, and these are related viruses, related diseases, the immunity gap has grown globally over the last 40 years. So, but this was a very slow progression, and it's taken collectively scientists and public health officials time to realize what was actually transpiring, that as the number of cases in Africa began to grow, and as a new outbreak took root in West Africa in 2017, it takes time to kind of frame shift, right? From oh, this is a zoonotic disease, it's localized, small outbreaks, they peter out all by themselves, until one day you wake up and say, oh, hang on a minute, actually it's manifesting person-to-person transmission in a way we hadn't recognized before. And in a population, in countries that have never seen it before, and in a population in which it's never been recognized before, which is among men who have sex with men primarily, not exclusively, of course, but primarily. And so we're dealing with very different situations, very different circumstances in different parts of the world. It makes it a very complex situation. and challenging to deal with and to talk about. So access is a two-way street. In order to access something, you sometimes also need to ask for it. And until now, this was not something that had been felt to be really necessary, as I say, in the early stages of the evolution of monkeypox on the African continent.
And at this point, when COVID emerged, we saw this sort of rush to develop mechanisms that could help to level the playing field with things like the ACT accelerator and other efforts like that, with which WHO was centrally involved in. Are there similar efforts that you're taking as WHO to tackle that equity issue and to bring these two campaigns against an outbreak and an endemic disease together?
Yeah, so WHO has been in a privileged position over the last 40 years, mandated by the World Health Assembly, which is the ministers of health of all the world, to oversee research against smallpox after its eradication. It's kind of a niche area, if you will. But those 40 years of research to prepare for an eventual outbreak of smallpox is actually what has yielded the countermeasures we have today. So the vaccines were developed for smallpox preparedness, the treatments were developed for smallpox preparedness. And so we've all had to kind of pivot, if you will, for a related disease, but which is milder, fewer severe cases, fewer fatal cases. And so the adaptation of, we have this suite of countermeasures, which was just coming to maturity, still not available in large quantities, still only sort of kept in reserves by a few countries, and still the research program was ongoing. And then now to see, can we adapt these products for use in a very different setting, in a very different population? And so WHO has been working very hard to ensure that we are coordinating between the companies that are producing, well, there are really only one or two vaccines at the moment, small companies producing these vaccines, and to increase production capacity, to increase the ability to fill and finish. And you were just hearing about what it takes to produce a medication from my previous colleague on this stage. So it takes time. It can take 9 to 18 months to produce a new batch of vaccines against smallpox or monkeypox. So WHO is working with member states and with other partners, manufacturers, to coordinate increasing access. But it is the process. It doesn't happen overnight.
One of the dynamics that we've seen in the past and that we've reported on at Devex is that there's a tendency to see clinical trials take place in the global south, research take place in the global south, and then to be sort of extracted from those communities, and the lessons and the information and the scientific advances are exported to wealthier countries. What is happening today in this outbreak to make sure that what we're learning and what is largely being motivated by the fact that this is spread to wealthier countries is filtering back to those communities where the disease is endemic, that have dealt with this for a long time?
Well, ultimately, we're learning quite a few things. So first of all, we're learning that a lot about the virus itself and how it can gain foothold in population groups that have certain characteristics, frequent physical contact, skin-to-skin contact, which is actually quite similar to what we knew before. It's just that it's found a way to spread, which has also taught us a lot about risk communication, how to offer information as a public health intervention. So being able to get the information that people need to have to protect themselves, to protect those around them, to understand their level of risk, to sort of say, well, this is where I am on the risk scale, so what can I do to reduce my risk? These are all really important learnings from this outbreak, not dissimilar to the learnings from COVID in terms of managing our own risk and protecting others. But each outbreak has its own characteristics. And so this continuous learning of how to communicate, how to navigate difficult things to talk about. People aren't used to talking about sex when it comes to outbreaks. Unless you've worked in certain sexual health services or HIV or perhaps gender-based violence areas of work, it's not something that most public health officials are comfortable with. So the whole effort to find the right language, work with communities, engage with affected communities. Dialogue is a two-way street. That's why it says dia, because dia means two, right? So dialogue is a two-way street. It's not just about providing information. It's about listening. It's about hearing what communities need. It's about hearing what they have to say. And this is all part of the learning package. Then the other part that you're alluding to is what we sometimes call countermeasures or vaccines and therapeutics. Studies are beginning to, well, they're already underway in a number of Western countries, if you will. European and North American studies are underway, both on the treatment and on the vaccines. So this is kind of a turning of the tables that we will also be able to apply now the outcomes of this research in the original setting where monkeypox is both in the human populations as well as in animal populations. So we will be able to benefit from the outcomes of these research to support countries that need it most, even after the other outbreaks have waned.
Great. Just a final quick question as I sort of invite my next panelists to gather somewhere near the stage. You mentioned that monkeypox particularly, but not exclusively, affects the population of men who have sex with men. How do you communicate that elevated risk? How do you draw resources to that population, necessary attention to that fact, without further marginalizing a population that is stigmatized and marginalized in a lot of parts of the world?
This is one of the biggest challenges that responding to this outbreak has faced, and that applies both in countries where it's perfectly fine to have sex with a person of the same sex as yourself, but it's also equally and even more challenging in countries where such activity may be criminalized or even punishable by death. So it's a critically important question, and the first part of the answer is that we need to work with the communities in the local circumstances and discuss with them, hear from them what they need. So, sexual health services can be provided almost anywhere. And those who've been working, for example, in HIV for decades, they've learned how to do this, and they have networks of their own. Both health professionals and community activists and leaders have networks of their own, and it's working with those networks that will get us where we need to be in terms of finding the right language, finding the right modes of communication, whether it be like this through mainstream media, whether it be through social media, whether it be through apps, even dating apps, whether it be through event organizers, and inviting everyone to come to the table to participate in helping to find the right language. And in this, as you point out, in this particular response, language is even more critically important than in some others, to be able to talk about how to reduce one's own risk, and also to reassure other groups of the population that may be over concerned. And so that each person can say, well, these are the activities that might put me at risk. How can I reduce my number of partners in a short period of time? Or how can I, in one setting or in a different setting, how can I, not expose myself to contaminated bushmeat if that is the way that I'm going to contract it in a completely different setting? And navigating what communities need by listening to them, and then working with them to co-create the messages and co-create the interventions that will help keep them safe.
Great. Well, Dr. Lewis, thank you so much. We're going to hear from some of the people who have been working on those challenges all the way back to the beginnings of the HIV fight. But thank you so much for joining us today from WHO. Sorry you were not here next to me, but it's nice to see your face nonetheless. Thanks again.
Thank you very much.